I want to share three studies about birth trauma. The first one sets the scene, why it happens, the risk factors, what we know it's linked to. The second goes one step further, not just an association, but about a definite link between cause and effect and the way forward to prevent it. And then the third study fast forward 5 years, and here we have a condition that affects almost 30% of women and that has the potential to impair early childhood attachment with long-term consequences for the family. How are we doing with robust solutions for better childbirth? Let's start with what I thought was a good definition. The power of this is that it doesn't imply any objective measure of distress to qualify for perinatal trauma. If you say your birth was traumatic, it was traumatic, as simple as that. It acknowledges that it doesn't always involve physical injury. And finally, it recognizes the role of care provision, either care systems or individuals. Most of us working in this space see trauma that isn't related to how the baby was born, but what was said or not said, language used, or feelings of abandonment in the early postnatal period. And that's an indicator of the quality of care received. The first study is a review of the research to date. Birth trauma is not isolated to any particular country, and it affects birthing people globally. The rate of post-traumatic stress after childbirth is almost 1 in 3, and it's clear that maternity health professionals need to have a better understanding of what's going on here. So what causes psychological birth trauma? Firstly, events during childbirth, such as fear for themselves or their baby, medical interventions, and especially if that wasn't expected, and a personal perception of self-worth. So medically, that means fetal distress, vacuum, forceps, cesarean section, and postpartum hemorrhage are all common precursors. As individuals, we all have varying degrees of personal resilience or adaptability if our expectations aren't met. And then there are cultural and environmental influences as well. In many cases, the birth experience appears uncomplicated to care providers. Birth events can be traumatic if there's a loss of dignity, a sense of control, and it can follow hostile or disrespectful interactions with healthcare staff. Another peri-traumatic hotspot is the feeling of being ignored, unsupported, or abandoned. Postpartum post-traumatic stress disorder, or PTSD, is a particularly severe outcome that affects almost 10% of people who give birth. As well as the risk factors already mentioned, it's more likely if pregnancy was unplanned, if there are financial challenges at home, after coercion to have labour induced or to use an epidural, and where postnatal support is either absent or there's a long physical recovery after childbirth. Another finding was that of the 14 risk factors for PTSD, 7 of them related to previous traumatic events in the lives of those who gave birth. Good social support afterwards can reduce the severity of post-traumatic stress symptoms, it alleviates recovery, and it's protective against developing PTSD. Positive relationships with midwives in labour has been found to be protective too. So this gives us a good understanding of what might be happening here. This second paper was from the UK, and they asked over 1,800 women at 6 to 8 weeks after their birth how it went. Similar risk factors for perinatal distress and PTSD were found, as in the first paper, but an important feature was that women's perceived control during labour and birth was even more important. They found that feelings of control can offset or have a mediating effect on post-traumatic stress symptoms. For example, the highly significant link between emergency cesarean section in labour and post-traumatic stress symptoms disappeared after adjusting for perceived control. It might sound obvious, but this is the first time it's been so clearly shown that it's not necessarily the type of birth that was experienced, it was an individual's involvement in the decision-making that's so critical. Perceived control, though, didn't offset the effect of severe illness or complications for their baby. And that's not surprising, because these are situations where there is genuine threat to life, whereas for an emergency cesarean, most often it doesn't have that immediate threat. The implications of this research are that us as healthcare providers need to make strong efforts throughout pregnancy, during labour, and immediately after to involve women in decision-making and improve their sense and the reality of being in control. So how are we doing at that? The final paper from last year reviewed national guidelines about training in birth trauma across Europe. And the answer is pretty poorly. Of 18 countries, only 1 had a national policy for the prevention, screening and treatment of birth trauma, the Netherlands. There is an absence of funded services in this area around the world and including Australia. 7 countries offered a few hours professional or pre-registration training, but none had nationally mandated post-registration training about birth trauma for either midwives or obstetricians. I think we have a lot of the answers already, and the time for action is well overdue. We need to start now by shifting our language and focusing more on empathy, empowerment, support, and promoting autonomy in every interaction that we have during pregnancy, labor, and after the baby's born.